either use a direct ophthalmoscopy or an indirect ophthalmoscopy. You can also use a fundus camera. So sometimes you might be shown pictures like this and asked to describe. So how do you do that? You start with medium. So you would report what it is. For example, if you're reading a CT scan, you will say, but this is a CT scan of the orbit, plane, contrast, seen through what, etc. So for reporting fundus findings, you would say, this is a fundus photo of the right eye or of the left eye. Now, do you know why I say this is the right eye?
Position siyang optic disc daw.
Okay, good. Because it's nasal, no? So you're oriented na, ha? And then next is you describe the media. So seen through clear media or hazy media. And then you describe the disc. So when you describe the disc, you first describe the color, if it's pink, if it's pale, if it's yellow. Then you describe the borders, if the borders are distinct. And then the CD ratio. I think you've had this before in the previous discussions. No, CD ratio is the cup versus the disc borders. Then we proceed to the AV ratio, which is the ratio of the arterioles versus the venules in the second branching. And then you describe the periphery of the retina, the temporal and the nasal vasculatures, if there's anything there, any lesions. And then you end with the macula. Okay? So for example, this is a fundus photo of the right eye seen through clear media. I see a yellowish disc with distinct borders with a CD ratio of about 0.4 with an AV ratio of 2:3. There are no lesions in the retinal periphery and macula. Okay? You can also say there's foveal contour is obvious or distinct foveal contour or reflex. Are you okay with this?
Yes, Doc.
Yes, Doc. Yes, Doc.
Okay, this is an optical coherence tomography. No, I think. Have you had the discussion on glaucoma already?
Yes, Doc. Yes,
Okay.
Doc.
So you probably heard of an OCT of the optic nerve already, no? And when we do an optical coherence tomography, it's like an ultrasound. But we don't use sound, we use light waves instead. But it gives us, similar to what an ultrasound will give us, it's like a cross section of the organ that you're examining. So in this case, we're using light waves to look at the layers of the retina. So you remember from histology, from the anatomy of the eye, that there are layers from the inside going out. So this is how you would see it in an OCT. So of course there are newer versions of an OCT, but this is a very clear OCT that shows you from the vitreous cavity towards the choroid. So if you can imagine lang those layers, this is a normal OCT of an eye. So it's like a living biopsy, diba? You're given a cross-section without having to remove the eye and cut it up. So you will see this is very helpful when you're talking about thickness, at what layer is the pathology, and etc. You okay with the optical coherence tomography so far?
Yes, Doc.
Okay, then we move on to fluorescein angiography. So angiography, it's a study of the vasculature. So in an FA of the retina, what we want to see are any abnormalities in the vasculature and if there's any leakage, if there's any blockage. So the first that fills up, of course, is the arteries. So initially, in the first 60 seconds, you see a complete refilling from the arteries to the veins already in a normal FA. There are early, medium, and late stage patterns of staining or leaking that we have to pay attention to. Of course, this one is normal. So you will take a look on the corners. You see the seconds and the minutes that they're taken. So in the very last photo on the bottom, you will see that it's late staining already. So that's already at 6 minutes. So the FA is usually done within about 10 minutes. All right, we're clear with this so far, huh? So next helpful thing for us, for helpful diagnostics in retina examination is the ultrasound. So we do an ultrasound of the eye. We still use the same, it's a probe. We use ultrasound waves to take a look at the characteristics of the lesions and the normal structures in the eye. So if you have an ultrasound that's seen through this, so from the front of the eye to the back of the eye, this is our orientation. So you can see all the layers there. Of course, the vitreous cavity is supposed to be blank. No, it's supposed to be hypoechoic like this. And then this is the posterior shadow of the optic nerve. Okay, we all oriented also in ultrasound na ha? So we can proceed with the clinical vignettes. All right, if we're all ready. So we have our first case here, a 25-year-old male medical student athlete who came to the ER for a sudden blurring of vision of only part of his visual field on the left eye upon waking up. So yesterday he was playing basketball and he was hit by his opponent's elbow. He noted brief flashes of light after the incident, but thought nothing of it since. He wears contact lenses for a grade of -6 on both eyes. So otherwise, his past medical history is unremarkable. When you took a look at the retina, this is what you saw. So first of all, can you describe to me what you see? Anyone? Shall we go back to our pattern, no? Somebody wants to answer?
Na shimmer, greenish fluid daw.
Okay. So how do we describe a fundus picture again? Let's go back, and if you can do a screenshot of how we read. Okay. Did you write that down or take a screenshot of this?
It's a
Again, so this is the flow of how we normally read a fundus. So when I ask you to describe a fundus, you describe it accordingly, no? So chronologically. Okay? So you're gonna take a screenshot of this so that when we discuss the different clinical vignettes, you'll be able to describe the fundus properly. Okay, we ready? All right, sige. Our first case again. Sige. Let's describe according to our guidelines. First of all, what is this? This is a fundus photo of the which eye? Anyone?
left eye daw.
Yes, left eye, no, because the case already says it's left eye. Also, your optic nerve is pointed nasally again, so this is the left eye. Sige. Seen through clear media, right? Still clear, you would agree?
Yes,
Okay. We have a yellow disc, we all agree? Distinct borders, CD ratio of about 0.3, we agree with that? AB
Yes,
ratio, probably still 2 out of 3. Okay, now we move on to periphery. Somebody answered something, no? Greenish. I forgot what you said.
Mershag fluid.
Okay, there's something like a fluid there, no? That's not supposed to be there. Anyone else?
it shows a large detachment, no?
Okay. Anyone else?
Tearing daw.
Okay, good. There's a large hair. All right. So there's a large there, no? It's a horseshoe type of tear. Okay. So what do you think? What you guys think this is?
This might be suggestive of a traumatic retinal detachment, though.
Okay. What's another word for traumatic retinal detachment? Hmm? So I gave you handouts. So there are 3 types of retinal detachment in the handouts.
Rheumatogenious daw.
Okay, very good. Rheumatogenious means there's a tear, no, regma. So in the history itself, what are the signs and symptoms that you would say points already towards a possible diagnosis of retinal detachment?
Really flashes though.
Very good. So, yeah, very good. So photopsias, no. So this could mean vitreoretinal traction or stimulation of the retina. So why is that? So you remember in physiology, any stimulus on the retina is transcribed as light. That's just how it is. No, the retina perceives light, just like your skin perceives either temperature, pain, and it's vibration, etc. No, the retina only perceives light. So whatever is happening there, if it's either a light stimulus or if it's a mechanical stimulus like this, it translates it as photopsias or flashes of light. Very good. So aside from that, what else?
So,
I'm sorry, what was that?
floaters, Doc.
Yes, it can present with floaters, but in this particular case, there's no floaters. No. So for this case now.
Blurring doc sa part sa visual field.
Okay, so sometimes they describe that as curtain-like sensation or a scotoma. No, so the patient's not going to tell you a scotoma, but they're going to say like there's like a cloud on the superior part or the inferior part of my vision. Okay, good. So what are the risk factors identified in this patient for RRD?
Trauma from
Very good.
What's-
Number one is trauma. What's another risk factor?
Contact lens.
High activities though, while playing basketball. This
Yes.
might be associated with trauma as well, Doc.
Okay, good. What else? I heard somebody say contact lens. Why contact lens?
The contact lens, Doc, would indicate high myopia po. That
Well-
would increase retinal tension.
Yeah, well, not the contact lens itself, but the grade that's given, no? Because you can have contact lenses for hyperopia and etc. So one of the risk factors identified here is because the patient is a high myope. So why do you think high myopes are at a higher risk for developing retinal detachments?
May retinal thinning doc.
Yes, why is it thin? Good.
Is because of the longer axial length, Doc, that would increase retinal tension.
Okay, good. So if you can imagine, no, myopic eyes are a little bit longer. So that means the retina is also stretched out a little bit more. So there are areas in the retina, especially along the ora serrata, that are thinner than other parts. Okay, so it's like when you imagine like a cling wrap that you stretch out, no? So of course the more you stretch it out, the more tension, the thinner some areas are. Okay? Next. How would you manage this case? So first, let's understand what the pathophysiology of retinal detachment is, no? So again, there's a separation between the neurosensory retina from the underlying retinal pigment epithelium. So somebody said there's like a greenish fluid. No, it appears green, but it's just a reflection. It's not actually green. It's just because there's fluid under the eye. So because there's a large tear, the fluid from the vitreous tends to insert itself between those layers, no? Because it's not firmly attached. So if you have a potential space there, the fluid's gonna enter. So that's how the detachment happens. Of course, there are other risk factors, no? So how would you manage this case?
Surgical repair doc.
Surgical repair, Doc.
Okay, good. So the surgical repair for retinal detachment involves, very importantly, pars plana vitrectomy. So what is pars plana vitrectomy? So kind of imagine this like laparoscopic surgery, no, except that you enter the eye. So remember, behind the lens is the vitreous cavity. So the vitreous, especially when you're still younger, it behaves like a gel. No, as you get older, it liquefies. So if you can imagine, for me, the white part of a fresh cracked egg, you know how the white part, the albumin part, tends to stick towards the yolk because it's more solid. No. So that's how it behaves. So it's also firmly attached to some parts of the retina. So, example, at the area of the ora serrata or the vitreous base, where the vortex veins exit, at the area of the optic disc, no, and at the area of the macula. So there are some areas there where the vitreous base or the vitreous gel is attached towards the retina. So, if you can imagine, because of those attachments, especially if your tear is along the ora serrata, so if that happens, no, so your vitreous will continue to pull on your retina, so it exacerbates the tear, it exacerbates the retinal detachment. So what you want to do is, before you can flatten it out, you want to make sure that you clean out the vitreous. So even if there's nothing wrong inherently with the vitreous, it's the retina that's the problem, you want to separate it, because otherwise the vitreous is just going to keep tugging on the retina. So remove the vitreous so that you can flatten it. Understand? Can you imagine the concept? Yeah, okay. So when you remove the vitreous, you have to replace it with something else also. So you can't just use saline. Eventually, it's going to be replaced with tears, no, or normal secretions at the eye. Not tears, sorry, aqueous, no. So what you want to do in a case of retinal detachment is, because you want to make sure that the retina is reattached where it was detached, so you have to replace the vitreous that you remove with something else. So, example, most of the time it is a highly dense na air bubble, gas bubble, or you can inject oil also, no, so that you can firmly reattach it. So another thing that you want to do in pars plana vitrectomy is, you guys are familiar with what welding is, no? So you kind of use lasers to make sure that you weld the tear back. So like you fix the hole with a laser. And then while you wait for the scar tissue to form, for it to reattach, no, after the laser, that's what the purpose of the gas bubble or of the oil is. Okay? You have can you grasp the concept? I know it's a little difficult. I don't expect you to go on, but at least have a general idea, no, so that when you become clerks later on and then you assist a case of vitrectomy, you have a general idea what's going on. Okay, any questions regarding, oh, you know what? I didn't show you the picture. So this is a picture of the pars plana vitrectomy. So we say pars plana because the trocars are inserted in the area of the pars plana. Okay, so why the pars plana? Because there's no neurosensory retina on that area. Remember, anterior to the ora serrata, there is no neurosensory retina. So if you can imagine, if you insert your trocars posterior to that area, so you'll be creating another tear in the retina, diba? So you want to introduce it in the area that's safe. Okay, so you remove the vitreous core, you replace it with either a gas bubble or an oil bubble, flatten it, and then create a scar with a laser. Okay, be clear?
Yes, no.
So of course, the earlier you repair it, the better. Remember that your retina derives its blood supply also from the posterior, no? So especially the posterior part of the retina, it derives also its blood supply from the choroid, right? The anterior 2/3 derives it from the central retinal artery, but posteriorly it derives it from the choroid. Okay, so the earlier you reattach it, the better the prognosis is. So the longer it goes without blood supply, of course, the worse your vision is going to be. Okay, no questions regarding retinal detachment? Good, we'll move on, huh? Next case, we have a 70-year-old female hypertensive diabetic, dyslipidemic, who came in for a 4-day history of sudden blurring of vision on the left eye. She claims she did not have any history of trauma. There was no pain, no redness, or other associated symptoms. She has a vision on the right eye of 20/50 and on the left eye hand motions. First of all, describe what you see.
There is clear media, doc, and well-defined margins of the optic disc.
Okay, good. So first of all, this is a fundus photo of the left eye seen through clear media. Okay, I'd say there's a yellowish disc. I guess the borders are kind of distinct, I guess. CD ratio,
May katong drug otoscope at thermoscope na. Mahal kayo.
0.2, 0.3.
Nagkan.
AV ratio,
15. Yan na friend.
2:3 still. Okay, sige, describe na lang the retina. What do you see aside from all the rest that we mentioned?
A cherry red spot in the macula, Doc.
Okay, good. Cherry red spot. That's good. Let's discuss the anatomical and histopathologic reasons for the cherry red spot. Anyone? Why is there a cherry red spot here? So where do you see your cherry red spot again? We are
In
considering
the macula, Doc.
Macula.
right, on the fovea, no? So what condition presents with a cherry red spot?
Central retinal artery occlusion.
Okay, very good. Is this pathognomonic for a CRAO? Like, isn't an isolated finding for CRAO alone? Have you encountered a cherry red spot before?
Wala pa doc, but most common siya sa CRAO doc.
Yeah. Have you heard of Tay-Sachs? Yes, diba? I thought.
Doc. Yes, Doc.
doc.
So it's not the only case that you see a cherry red spot, huh? Okay, anyway, sige. Why do we have a cherry red spot in CRAO?
Na-preserve yung choroidal perfusion, Doc.
All right, good. What else?
The retinal ganglion cell layer, Doc, becomes edematous and ischemic.
Okay, so what happens if it's ischemic and edematous?
Mag-retinal whitening, Doc.
Good. So you see the background choroidal flush that is preserved against a background of white edematous retina. So that's why it looks red. So why in particular in that area, man? So yes, it's preserved. Yes, the rest is white. But how come you can see that? Think back to histology and the OCT and the layers of the retina. What happens in the fovea? What is different in the fovea than the rest of the retina?
It lacks ganglion cells, no?
Okay, good. Remember that it's the rest of the layers are swept back, no? So that in the fovea, the reason why it's the area of most acute vision, aside from the 1:1 configuration of the cones and photoreceptors and the ganglion cells, is because there's no additional layers, no? So whatever light enters directly to the photoreceptors, correct? So it's thinner on that area. You don't have the swelling, you don't have the edema because it does not have that layer. So aside from that, you see the background flush, because when you have a central retinal artery occlusion, there's nothing wrong with the choroid, So the choroid is well vascularized. It's just that the rest of the retina, the anterior retina that becomes edematous, looks white because it's ischemic. You get it? So we can explain why there's a cherry red spot na in CRAO. Is this considered an ophthalmic emergency in this case? You've discussed ophthalmic emergencies already, no? With Dr. Did I do? Anyway, did you discuss emergencies?
Yes, no.
So in this case of a 70-year-old female with a 4D blurring of vision, is this considered an emergency, ophthalmic emergency?
Yes, doc.
CRAO is an absolute ophthalmic emergency. We all agree?
Yes, no.
Why? Okay, very good. No. So the first premise is it's an emergency because you have to institute whatever treatment it is within the next few minutes to hours, correct? There's a golden period for which you can only administer treatment in the hopes of reversing vision loss, correct?
Yes, ma'am.
Yeah, so in this case, it's already 4 days. Is this still an emergency? Considering that we're past the golden period for CRAO?
I think mga lado.
So you'll send the patient home na from the ER. Okay, we can't do anything about it. We agree? Or does anyone disagree?
I think you can agree to that.
Okay, I do disagree. Why? Because somebody mentioned, no? What is the patient at risk for?
Vision loss, Doc.
Aside from vision loss, because we already have hand motion. So
Stroke, high risk of stroke.
Belacho, what did you say?
High risk of stroke.
Okay, good. No, so even if we are ophthalmologists, we are still medical doctors. No, so what happened here is this is highly likely this was an embolic event, right? So if the patient had an embolic event here, they are at risk for developing strokes. Aside from that, no, cardiovascular incidents. Right? So do not discharge the patient. Make sure that you refer the patient to the stroke unit, to the IM doctor, no, for workup. Okay, so even if you are past your golden period for treating CRAO, you still treat this as an emergency because there is a risk for the patient's life. Okay? So it's not an emergency eye-wise, but it's still an emergency generally. If this was more acute, what can you do to manage this case as like an intern in the future?
Acute treatments can include ocular massage, anterior chamber paracentesis, and hyperbaric oxygen, Doc. But
Okay, so
this
yeah.
would also indicate inconsistent success as well.
Yeah, so anecdotal lang, no, you can't really promise the patient that you can reverse this, but the premise is you want to knock that occlusion off, no, so you want to push it further back into a smaller area. So even if there's still occlusion, it's going to be a smaller area, not central, not the whole retina anymore, no. So when you do ocular massage, how do you do that? There's echo. Is that okay? You press on the eye with your thumb for at least 10 seconds and then release. No, press again and then release. Okay, so you repeat that several times until you've dislodged it. Historically, there's also brown paper bag breathing. So what you want to do is increase the carbon dioxide content in the blood. So when you do this, you tend to dilate the vessels and then push the plaque further down there, or the embolus further down. A better way to do it would be to do paracentesis, as you said. When we do anterior chamber paracentesis, you withdraw some of the aqueous so that you soften the pressure of the eye, so that you also decrease the venous pressure and the arterial pressure. What's the other thing you said? That's it, no? Okay,
Hyperbaric oxygen, yes, Doc.
Yes, hyperbaric oxygen also. That operates in a different mechanism. No? So it's supposed to increase oxygenation in the retina. Okay, so remember we talked about okay, there. Remember we talked about fluorescein angiography. So this is how it would look for a CRAO. So you see that there's no perfusion through the central retinal artery, but there is perfusion through the cilioretinal artery. Can you see that? That area in the macula that's vascularized pa? Yes? It's
Yes,
filling. So the rest is blocked. Okay, good. Next case, we have a 46-year-old female, poorly controlled, diabetic, and hypertensive, presenting with sudden painless blurring of vision in the right eye. This is what the retina looks like. Describe what you see. Anyone? What's the medium? What are we looking at? This is a
Fundus of the eye, Doc.
of the
Right eye.
Of the right eye. Good. Seen through. Sige, kamu daw. Speech. So if you can see very well the structures in the fundus, then that means that the media is clear. So when I'm saying seen through clear media, then that means your what are the optical medium that you have to go through, media that you have to go through in order for you to check the retina. Number 1, cornea. Number 2, the aqueous. Number 3, the lens, and then number 4, the vitreous. Right? So if all these layers are clear, then you can see the retina. So you can say seen through clear media. So in case where you have to examine the fundus in a dense cataract, of course you would say seen through hazy media. Or if the cataract is so mature that you cannot see, then you can see there's no view of the posterior pole because of dense media opacity or dense lens cataract. Gets? So that's the importance of mentioning the media. So, of course, the clarity affects the accuracy of your descriptions also and on the laboratories. Okay, so this is a fundus photo of the right eye seen through clear media. Showing. Next. What do we see?
Dot and flame shaped hemorrhages, Doc.
First, we describe the disc. Yellow disc with distinct borders, yes. CD ratio 0.4. AV ratio is probably 1:4. I would say 1:4, 1:3. So I know it sounds silly, but you have to go through the motions. Even if it looks normal to you, you have to describe it from the outside going in. You have to follow chronologic, because sometimes you miss some things if you skip. So it sometimes if you don't train yourself to think like that, if you're looking at the patient, for example, and you see like a huge whatever lesion on the face, so you go directly to the lesion and you forget the rest of the which can lead to a lot of errors in your impression. So go through the motions lang. All right, so let's say we've done the description. So because we mentioned dot and blot now, we did not check on the AV ratio, which is very important in this case. So go through the motions, good. So AV ratio is 1:4. And then you said dot and blot hemorrhages, I agree. What else? What type? There's another type of hemorrhage there.
Pre-retinal, Doc.
I'd say intraretinal. How would an intraretinal hemorrhage look like? Actually, all of these are intraretinal hemorrhage. It depends on the layer of the retina that the bleeding occurs. So remember the characteristics of each layer of the retina. I'm talking about the flame-shaped hemorrhages, by the way, which we missed. So dot and blot, yes. Flame-shaped also. So in the layer of the retinal nerve fiber layer, remember the nerve fibers go, the layers are like hair, It goes in strands. So if the bleeding is in that layer, then of course it looks like strands also. So flame-shaped hemorrhages, those things that look like flames. Dot and blot, they occur in the nuclear layers, So there are spaces in between in those layers, so that's why they look like globs. Okay? Sige. Next. What's your impression?
Central retinal vein occlusion.
Okay, good. It looks completely opposite to the CRAO, And looking at it, you would say that it looks like an emergency, The eye looks very congested. But do we consider this an ophthalmic emergency, like CRAO? There are two absolute emergencies in the eye. What are they?
Chemical injuries, Doc.
Good. NCRAO. And there are relative eye emergencies as well, which include acute angle closure glaucoma, globe rupture, etc., etc. Is CRVO included in the list of ophthalmic emergencies? It's not a trick question. It's just a yes or no question. Is it in the list of ophthalmic emergencies?
Yes, Doc.
Yes. Yes.
Is it?
No.
Yeah, it's CRAO, diba? In the list of ophthalmic emergencies, not CRVO. So, well, it's not less devastating than CRVO because you will still have a pretty bad vision in this case, but what constitutes an emergency, an absolute emergency, is if you don't institute treatment right away, then that means that the patient will get blind. No, in this case, there's nothing you can do that can reverse it. So it's not technically an emergency. You get? That's it. Okay, how about this, Jay? Describe what you see. So practice. Those are my questions for CRVO. Very gamay or Jay? Describe what you see, and then what's our impression here?
Fundus of the left eye seen on clear media, Doc.
Mm-hmm. Go on. What do you see through clear media?
No opacities, Doc, clear.
Yes, good. Seen through clear media. What is it that we see? Yellow disc with distinct border, CD ratio of 0.3, AV ratio of... Wait, let me see if I can... So when we're looking at the AV ratio, you look at the second branching, huh? Wait, let me move this out of the way. That's the first branching. This is the second branching. Sorry, the thing is right on my way. But anyway, after that, no. So you can't look at the first branching, look at the second branch. So after that, there's a second branch, no? That's what you compare, huh? Okay, you might be wondering, ano man siyang nag 2:3 man siya? Reglahi man yung ratio. Are we guys on the same page? Do you understand? Or if there's any questions, if it's not making sense, you ask, huh? Are you clear so far with reading the fundus from the medium towards the AV ratio? Were you taught how?
Doc, okay rin as to mga ratio, Doc.
Yeah.
Kung how to
So, Doc,
Yeah, of course. So wait, ha, I don't know how to show my pointer without ruining the thing. Wait, so sorry about this. Okay, I'm using my phone for the sharing of the screen. And dili ko siya mo padaplin. Anyway, if you can imagine, no, this is the first branching. This is the second branching, but I cannot use the superior part, manggod, because this is the area of the pathology, no. But ideally, kaning ubos inyong tanawon. Okay, so I cannot draw on the lower part because the pictures, what's the icons are there. But this one is the first branching. But you look at this area. Here, you look at this area. This is freaking frustrating. But you get what I mean? No, basta that's this one. This is what you compare. So this is the artery. This is the vein. So ideally, your artery should be smaller than your vein. We agree?
Yes, Doc.
Okay, good. So you look at the second branching of the artery in comparison to the vein. So just how thick it is compared to the vein. So normally it looks similar, no, or a little bit close. So if it's a grade of 2 versus a grade of 3 sa imuhang vein. So that is why when we looked at the, let's go back to CRAO, huh? Wait, let me see if I have a nicer picture for you. Let's do CRVO. So in a CRVO, the problem is drainage, diba? So there's a block in the drainage. So what happens is there's congestion. So because there's congestion, there's an increase in the pressure. Ideally, it cannot come back. No, so there's a higher pressure in your venous system. Diba? That's why it's congested. So your veins will look engorged, no? They look tortuous, they look bigger. So that is why I said that the AV ratio is much bigger in this case, so like a 4. You get? Wait, huh? Let me see if I can. First branching here, second branching. Can you see the arteries versus the veins?
Yes, Doc.
Yes, Doc.
Doc.
How about the CD ratio? Are we clear with that? This is the cupping. This is the borders. So if you're thinking of the whole disc as a whole, the ratio of how small your cup is versus the whole lang. So ang normal, I'd say, is a 0.3 or 0.4. It depends, no? So some people have bigger discs, cuppings than the rest, but it does not mean it's glaucoma, no? So sometimes some families have bigger disc cupping than others lang yun. So a 0.5, a 0.6 can be normal for you as long as it's symmetric. So your right eye and your left eye should have the same cupping. And then when you work up in the OCT, no, there's no signs of damage. And that can be normal also. Okay? So if more or less normal, if you're not dealing with a case of obviously like this, no, 2:3 is like the regular nga makitaan na to. It just needs practice lang. Okay? Did I help? Or di yapon siya klaro?
Para practice lang.
Sige. Maybe I can send you some fundus photos also. No more fundus photos for practice lang. Sige. So let's get over that na. What do we see na lang that's abnormal? So it looks a little bit the same, no? We have dot and blot hemorrhages. We have flame-shaped hemorrhages along the retinal nerve fiber layers. But it does not involve the whole retina. So this is a case of
Branch retinal vein occlusion, Doc.
okay, very good. A branch retinal vein occlusion because it's only a branch. You will also see on some areas here there are cotton wool spots. No, what does a cotton wool spot look like? It looks like that cotton ball. There are about 4 spots there that look like cotton wool spots. Okay, what's your impression? We already discussed impression. Again, not an ophthalmic emergency. Next case is a 30-year-old type 1 diabetic, which was diagnosed since childhood, consulted at the OPD for gradual blurring of vision on both eyes. This is a picture of the right eye. Let's describe what we see. That's the branching we should take a look at. Fundus photo of the right eye seen through clear media shows us a yellow disc with distinct disc borders, CD ratio of about 0.3, AV ratio, I still say it's about 2:3. We agree? Sige. Let's take a look at the retinal periphery. What do you guys see there that should not be there?
Blood, no?
Blood, no? So what kind of blood?
Dot blood hemorrhages, Doc.
Very good. Dot and blot hemorrhages. What else?
Cotton wool spots.
Very good. There's also cotton wool spots, no, notably in the inferior vascular arcade, inferotemporal vascular arcade. If we take a look more closely, we'll probably see areas of retinal microaneurysms and etc. there. You will see that the vessels are also more tortuous than normal, no? So sometimes this can be abnormal or sometimes it can be normal because some patients have more tortuous vessels, but ordinarily the vessel should follow like almost like a straight course, no? Like the normal fundus that I showed you earlier. So what's our impression here? Based
Diabetic retinopathy, Doc.
Good, diabetic retinopathy. So I'm not going to torture you with asking you now what the grade is for diabetic retinopathy. It's a little difficult, no? So what are the risk factors for developing diabetic retinopathy?
Duration
What's that?
duration of the diabetes.
Okay, that's the single most important factor, no? Duration of the diabetes. So even if your patient says, I have very good control, no, for 15 years, how can I have diabetic retinopathy? The answer there is because you've been diabetic for 15 years. No, it's not, of course, it is still a factor of the control, but the bigger risk factor is how long you've been diabetic. So if the patient has been diabetic for more than 5-10 years, chances are there's some, at least background diabetic retinopathy or mild diabetic retinopathy. Okay, aside from that, duration,
Or
Very
control, Doc.
control, Doc.
for control.
Hypertension, Doc.
Okay, good. What else?
Hyperlipidemia.
Okay, all those other systemic risk factors. No, pregnancy increases the risk for developing diabetic retinopathy because it messes more with the control of the sugar. Also, in pregnancy, there is higher levels of vascular endothelial growth factor. So you will note later on, no, VEGF can be a good thing or a bad thing. Generally, in ophthalmology, we're against vascular endothelial growth factor. So in cardiology, they like vascular endothelial growth factor because they want to revascularize the cardiac muscles. No, in ophthalmology, we don't want these abnormal vessels. No, so we will use a lot of anti-VEGF medications in this case. What else? Next question. Okay, we're moving on to the eye. We have a 60-year-old male presenting with blurring of vision on both eyes, headache lasting about a week. He has a history of coronary artery disease and uncontrolled hypertension. This is what his retina looks like. Can somebody describe to me what you see? Oh, don't be alarmed. No, nganong duha ka buhok yung retina. So sometimes when we take photos of the retina, it's a little hard to get a big picture because of the curved nature of the eye. Diba? So when you're taking a picture, we have to get several views, no, of the sphere. So sometimes it's a composite of pictures. We have to piece it together like this, so you get a flat lay of the whole retina. So it's not two retinas. It's just how we present the picture. Sige, go ahead.
Media of right eye, Doc.
Mm-hmm. From this photo of the left eye.
Eye and no opacities, Doc.
Okay, seen through clear media, agree. And then
Vessels are dilated.
wait, the disc.
Orange disc, Doc.
Okay. Go on.
blurred disc margins, doc, that would indicate papilledema.
Okay, very good. I agree with that part. No, the disc borders are indistinct or blurred disc borders. You can also say maybe it looks swollen disc. Good. You also cannot clearly identify the CD ratio, right? Because you cannot identify the disc margins anymore. And then you said dilated vessels. Which vessels? Is it both the arteries and the veins? Is it only the veins? Is it the artery? So if one of them is dilated, what is your ratio? Remember the pathology in uncontrolled hypertension. Not just in the eye, and the rest of the vasculature.
When is the 3, Doc?
Okay. Good. So what happens in a case of coronary artery disease? Peripheral artery disease, any arterial diseases?
There can be ischemia, Doc.
There's sclerosis in the arteries, right?
Yes, Doc.
Yes, Doc.
Cannot zoom in. Yeah, I cannot zoom in there. Okay, so I agree with you. No, there is an imbalance in the AV ratio already. So you will see narrowing in the arterioles and widening or tortuosity of the vessels. No, well, not torture, engorgement of the veins. What else do we see? Cotton wool spots. It says there. Flame-shaped hemorrhages. Yes. Dot and blot hemorrhages in the periphery as well. And then in the macula. Can you see?
There is macular edema, doc.
Okay, good. What makes you say it's edema? Because there's loss of the normal foveal contour, right? There's usually a dip in the fovea. There's a foveal reflex. In this case, it's not. No, it's blurred. So normally you can't really tell it's edema in a two-dimensional picture like this, but when you're looking at the patient in actuality in the direct ophthalmoscopy or in the indirect ophthalmoscopy, you will see that the retina is kind of elevated. No. So in this case, we have some visual cues that there is macular edema. Number one, because there's loss of the normal foveal reflex. No, there's loss of the contour. And number two, because there are hard exudates in that area. Okay? Sige. What's our impression in this case?
Hypertensive retinopathy, Doc.
In this case, it's very easy to grade hypertensive retinopathy na. So when we get to this stage, it is already grade.
3, Doc, or 4?
When do we see that?
Doc.
3, Doc.
Do we agree, everybody?
Yes, doc. Grade 3.
Sige. Defend lang ha why you said grade 3, not grade 4. And maybe I'll bring that out in the exam lang.
Or maybe 4, Doc, yun na may papilledema, Doc, plus the presence of your flame-shaped na hemorrhages.
Okay, so grade 3 plus the disc swelling is grade 4 already, huh?
Yes,
So,
doc.
yeah, so important because that is already severe, no? Or that's malignant hypertension already. Another thing, you notice that I'm not agreeing with you that it's papilledema. What is the difference between papilledema and disc swelling? Why am I just saying it's disc edema? It's papillitis. It's not papilledema. What does papilledema signify?
So optic disc swelling, doc, is a general term for disc edema, whereas papilledema is optic disc swelling due to increased intracranial pressure po.
Very good. No, so I don't have any picture of what the other eye look like. So I'm not going to say it's papilledema. Also, the underlying pathology is markedly different. Huh? Okay, so if you have disc swelling because it's pushing from the increase in the intracranial pressure, that translates through the CSF. Diba? Remember that your eye, your optic nerve, is an extension of the central nervous system. It is covered by the same neural coverings that cover the central nervous system. So if it's the optic nerve is actually bathed in CSF, correct? So it runs its course towards the back of the eye, completely bathed in CSF. Do we agree? Can you imagine it or picture it for me? Say yes.
Yes,
Okay.
Doc.
Good. So
Yes,
if
Doc.
it's going to increase in the pressure, then it's going to translate there. Okay. Sige. We're all on the same page. So not papilledema, just either papillitis or optic disc edema. Okay? Not interchangeable ang terms. Next case. A 2-year-old boy presenting with strabismus. Strabismus is misalignment of the eyes. There's a family history of notable osteosarcoma in the father's side. Physical examination findings, again, strabismus and leukocoria. What's leukocoria, Gani? Have you heard of this before? Leukocoria.
White spots sa eye, Doc.
White reflex in the eye, no, or cat's eye reflex. He is referred to the pediatric ophthalmologist for further evaluation. So this is what the leukocoria looks like. Huh? Right eye leukocoria. So it's called the white cat's eye reflex because it looks like, at night when you shine a light in lower animals like the felines, there is a reflection of the light. So that's what it looks like. So normally that's not in humans. No, there is a layer of the retina in lower primates or lower mammals that is not in humans. No, so they need this for good night vision, but we don't have that. No, that's called the tapetum. So if you have a reflex like this, then that means there's something wrong. Okay, so you're supposed to have a red-orange reflex, diba? Describe what you see then. So again, there is a white reflex. No, so when you say leukocoria, you have to differentiate also where that opacification is in the media. So remember, you have to tell us if it is in the cornea, if it's in the lens, or if it's more posterior. No, is it in the vitreous or is it in the retina? So the only way to tell for sure is to do a complete eye examination. So in this case, with a differential of cat's eye reflex in this particular age group, what is the most important differential you should be considering?
Retinoblastoma.
Why?
Retinoblastoma.
Okay, perfect. So why is it a very important differential? Because it is
Most common, Dr.
Common primary.
Present in children under 5 years of age, Doc.
yes. So that means it's life-threatening. No, so it's very important that you consider life-threatening conditions before the. Of course, there are so many causes of possible leukocoria in a baby like this, but the only life-threatening condition is retinoblastoma. So unless proven otherwise, patients in this age group presenting with cat's eye reflex should be worked up for retinoblastoma. Are we on agreement for this? So anytime you're in the community, whether you're rotating in pediatrics, whatever, and you see a patient that looks like this, always refer as soon as possible. Okay? So say you're rotating in ophthalmology, or if you're assigned in the far-flung barangays that you don't have a nearby Ophtha, but you have some access to laboratories, what would you recommend to confirm your impression? So you're thinking, oh my goodness, this age group, leukocoria, I want to do something before I send the patient to the city or whatever. So what do you want to request first? What do you Okay, you can do a B-scan ultrasound. What else?
MRI, Doc.
Okay, you can also do an MRI. Very good. Anyone else?
Endoscopy, Doc.
What's that? Fundoscopy.
Yes, Doc.
Yeah, I agree. No, so the easiest way to tell for sure is to do a simple fundoscopy. So if you see a mass on the retina, graft right away. No, aside from MRI, ultrasound. And fundoscopy, of course. You can also order
CT scan, Doc.
Okay, very good. So in this case, we opted to do an ultrasound because it was cheaper. No, so in ultrasound, you see suspicious of retinoblastoma. Why? Because there is calcification. So calcification will show up as posterior shadowing, which means in calcified tissues like bone, of course, you won't be able to see anything else penetrate. No no sound waves will penetrate calcified tissue. So do you know why there's calcification in tumors like retinoblastoma?
Necrosis, Doc. Due to malignancies.
Very good. No, so you can do an MRI, especially in cases like this, if you have a history of osteosarcoma in the family. This means there's a possible strong history of CA now. So in this case, if it's heritable, there's history of osteosarcoma. Most likely it might be bilateral or trilateral, meaning there's a risk for cancer elsewhere in the other eye, in the pineal body, or in the bones. No, so if you do a CT scan, there is an increased risk for this patient being exposed to radiation, no, versus an MRI. You can certainly do an MRI. It's safer for the patient. It is more expensive though. Generally, though, for most of the population, if you just want to confirm your diagnosis of retinoblastoma, you can still do a CT scan because a CT scan will show calcification very well. It will not show up in MRI. MRI is a little bit more useful if we're tracking the progress or metastasis now. So if we're looking at whether the retinoblastoma has spread in the orbit or in the nerve, then an MRI would be superior because it gives us better soft tissue details, no? But in cases of calcification, CT scan is still best. Okay, good. Can we move on from this? So this is what a retinoblastoma looks like. It can be big, it can be small, no? So depending on how big or the retinoblastoma is and where the metastasis is, we usually grade it. No, there are different grading systems that we use. Reese Ellsworth, there's the international classification of CA. The grading systems are there for a reason. It's not just for us to torture you into memorizing it. It will guide prognosis and management. So you don't just shotgun. No, you can't remove the eye. It's not easy for the patient and for the family to accept that you suggest removing the eye right away. So you have to give them a little bit of hope. No, so if the lesion is not too big and it's conducive for photocoagulation, then you might offer laser. No, so in that case, the patient does not lose the eye. If there's some workable vision, you can save the eye. But the priority when we're dealing with retinoblastoma is always number one, to save the life before we save the sight. Okay, so if it's big na, if there's metastasis, then we have to do enucleation. When we're talking about enucleation, it is the removal of the entire globe, including some parts of the optic nerve, knowing that the most common spread of the retinoblastoma is still through the optic nerve. Okay, any questions regarding this?
None so far, no.
So we mentioned also strabismus, the eye. Retinoblastoma is one of those great mimics, no? So you can present with many other things. It can present as redness, like an infection. It can present like a cellulitis, uveitis. It can present as cross-eyed, no, or glaucoma. So again, in any of these presentations in this age group, always rule out retinoblastoma first. Okay, we have a next case, a 60-year-old female dyslipidemic who smokes, presenting with distortion of the central vision, described as the inability to identify people's faces. This is what our retina looks like. Let's describe again. Perfect na nga description, kay I think this is our last case.
Fundus photo of the left eye seen through clear media, Doc. Then yellow this with clear borders.
Go on.
CD ratio of 0.2, Doc. AV ratio 2 is to 2 to 3.
Okay. Very good. Perfect first part of fundoscopy. Next. I'd say it's about a 0.3 though, but it's subjective. Sige. Do we see anything in the retinal periphery? No lesion seen on the retinal periphery or along the inferior and superior vascular arcades temporally. But what do we see on the macula? You can describe lang, so you can say there are multiple areas of hypo and hyperpigmented lesions, no? Some people will say it's geographic, it's yellowish lesions. You're okay with describing lang yan. So if you don't know the technical terms, it's perfectly okay to describe them. What's the possible impression for this lesion? Since it's in the macula, we're thinking about maculopathies. No, one of the most common maculopathies in a 60-year-old is still
Age-related macular degeneration, Doc.
very good. No, so what are the risk factors for developing AMD?
Age.
Good. Advancing age. What else?
Family history.
Smoking, Doc.
Good. So it's all in our handouts. So very important is age, family history, and cigarette smoking. Of course, the others are contributory, but most of the time, these are the very, very important risk factors. So what's the treatment for AMD? It depends on what the cause is. No, so there are two types of AMD. There's the dry type and the wet type of AMD. It just depends on the pathology. Some people will say also that the dry type of AMD eventually will develop into wet AMD, but not really. No. If it's the dry type, so take a look at the OCT. No, you have the corresponding flattening, but there are drusenoid lesions on the chorioretinal junction. Versus the wet AMD, you see an area of leaking there. No, so the pathology is around the area of the Bruch membrane. It's wet because it's vascular. No, there's development of angiogenesis. No, there's CNV. Again, I mentioned about vascular endothelial growth factors. No, so if there's ischemia on this area, chances are the levels of VEGF will increase. The problem is the new vessels that are formed are abnormal, they're friable, they're prone to breaking, just like in diabetic retinopathy, diabetic retinopathy and in retinopathy of prematurity. Oh, I did not discuss that, but hopefully the pediatric person who will discuss ROP with you. Did you have discussion on pediatric ophthalmology na? Not yet. Okay, sige. I'll make sure that they include ROP lang, but I'll follow up with more handouts on ROP lang. I'm sorry I did not get a chance to include this in our clinical vignettes and our handouts. So it's a very, very important disease, no, retinopathy of prematurity. It happens in babies at risk for say they're younger than 31 weeks old, lighter than 1,500 grams, no? So make sure lang na we read through it lang in case the Kuan people do not put emphasis on this, because it's a potentially blinding condition also. And then you can save the vision of the baby if you only know how to manage and how to refer early. Okay, anyway, going back to AMD, how do we treat it? So it depends if it's wet or if it's dry, no? For dry AMD, because there's nothing that we have to treat, this is the only time we actually give vitamins, no? So a lot of the patients who come in our clinic will usually ask us, can I take vitamins for the eyes? My usual answer is yes, you can, but I don't see any reason why you have to take supplements unless your diet is markedly replete and depleted in vitamins na po, no? So if you eat a balanced diet, you usually have most of the vitamins and minerals that you need. In this case, you will benefit by taking the AREDS formulation of vitamin C, vitamin E, lutein, zeaxanthin, no? So you will notice nga it's thrown about left and right, no, sa mga supplements, especially the herbal supplements that you hear on TV, no, lutein, zeaxanthin, etc. Nobody actually needs it unless you have the familial dry AMD. So you don't have to take that. No, as a matter of fact, especially for patients who smoke, if you take a higher dose of vitamin A, lutein, zeaxanthin, you are at risk for developing CAs, diba? Vitamin A. So only for patients who need it lang. For wet AMD, because the problem here is neovascularization, we do give injections of anti-VEGF, example, ranibizumabs, bevacizumabs, and etc. You can also destroy those abnormal vessels with laser, PDT, and etc. Photodynamic therapy. Okay, I think that's the last clinical vignette I presented, but I will send through Henry lang additional notes on ROP because I missed that. Good. Do you have any questions in our discussions? Of course, the handouts I gave you were very, very, very shallow, no? So it's still a good idea to read up on the books. Kansky is a good book for pictures, but it does not give a very good discussion. If you want a thorough discussion, I'd say hit the AAO, American Academy of Ophthalmology books. I think you have that in your library, Rapid, or you can download the pirated version. You had an exam already, no, on the previous topic that I gave you. I think I gave you clinical vignettes also and handouts. Do you think this is an effective way for you to learn, self-directed learning and application like this, or would you prefer lecture yun next time? I think I have probably one more topic with you guys. Do you want to lecture, or do you think this is effective?
I think okay ra ni Doc, but naglisod lang ni ho. Catch up sa... I think okay ra ni Doc, but naglisod lang ni catch up sa mga pictures para mabot ng ora-ora.
Okay. How were your exam results from last time?
Wala pa scores ba?
How no score ka? Balaba. How are you related to Janet? I have a student in CNU also, Balaba.
Not related me, Doc.
Nino says lecture. Okay, I'll try my best to prepare a pre-recorded lecture for you guys now. I find lectures kind of boring. It's not interactive. It's not, unless we do it in person, because when I do lectures, I usually insert the clinical vignettes within the lectures. Okay, kapoy kayo being talked at, especially if it's online. You're probably going to be doing something else anyway. So I will try my best to give you a pre-recorded lecture, so whoever needs the lecture can go along with the lecture. Okay?
Thank you, Doc.
Sige, no questions regarding this or the previous topic? We're okay?
Doc.
Okay.
Yes, Doc.
Sige. Thanks, everyone. Have a good evening.
Thank you, Doc.
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 Thank you, Doc.